welcome to the debate. Let's start this episode of the debate with the sound of a cardiac monitor alarming frantically.
The sound of a cardiac monitor alarming frantically.
This debate is brought to the listener by Whole Life Healthcare. Alarm fatigue can affect, well, all aspects of patient care. It also has its effects on the healthcare worker. Don't forget to pick up our EKG Survival Pack, and also you can find us on YouTube and Spotify.
Yeah, thanks for tuning in, everyone. Today, we are really digging into that sound you just heard, because honestly, it's a sound anyone who has ever stepped foot in a hospital knows instantly.
Oh, instantly. It is piercing, it is relentless, and according to the Joint Commission, it has actually become a national patient safety emergency. So, let's have a debate on, should healthcare workers and clinicians stop alarms within a certain time frame in order to reduce and prevent alarm fatigue?
Right. The main goal of this debate is to bring awareness to alarm fatigue and solutions, like what telemetry monitor techs can provide to help reduce that fatigue. And this really is an emergency driven by pure mathematical volume.
Yep.
The Joint Commission elevated alarm management to a national safety goal because, and this is wild, an estimated 85 to 99% of alarm signals in hospitals do not actually require clinical intervention.
Wow, 99%. That's just...
Yeah, we are talking about tens of thousands of alarms on a single unit every single day. The result is a workforce that just becomes completely desensitized to a constant barrage of noise.
Exactly. I mean, clinicians might turn down the volume or, adjust the settings outside safe limits just to get a moment of peace. Or they might simply block the sound out entirely. And the consequences of that desensitization, well, they're fatal. When you are bombarded with hundreds of meaningless beeps per patient, per day, the true, life-threatening alerts just get lost in the static.
Which really brings us to the core of our discussion today. We are wrestling with a fundamental question of system design here. Should healthcare systems rely on dedicated technicians to filter alarms within a certain time frame to reduce fatigue, or
is there a completely different approach we should be taking?
Right.
We are examining two very different philosophies of alarm management today. I am going to be arguing for centralized filtering. I propose that dedicated telemetry monitor technicians should act as the primary filter for all patient alarms. By sitting at a central station and actively reviewing the data, they essentially shield the bedside staff from the noise of non-actionable alerts.
And I will be arguing for direct nurse accountability. I propose that, inserting a technician as a middleman treats the symptom rather than the disease. Empowering bedside nurses to directly manage, customize, and adjust alarm settings at the source, meaning the patient's bedside, is the safest and most sustainable strategy for actually eliminating alarm fatigue.
Okay, so let's lay the groundwork here, because I think we really have to appreciate the staggering volume of data we are asking bedside nurses to process. If you walk onto a standard telemetry floor, you have patients hooked up to monitors measuring continuous electrocardiograms, blood pressure, oxygen saturation.
And it just never stops.
It never stops. The Journal of Hospital Medicine published this fascinating retrospective study looking at a 545-bed urban academic hospital. Over just a 2-month period, the telemetry system generated 20,775 alerts.
Wait, over 20,000? In 2 months?
Yes, it is an astronomical number. It's an impossible cognitive load for a bedside nurse. You have a professional who is also administering highly sensitive medications, coordinating care with physicians, and providing physical, hands-on care.
Right.
So in this study, the hospital utilized dedicated monitor watchers at a central station. Those technicians intercepted 87% of those alerts, dismissing them as non-actionable before they ever reached a nurse's phone. That is over 18,000 interruptions prevented.
Okay, I look at that exact same study, but I come at it from a fundamentally different angle. When you see an 87% interception rate, you have to stop and ask yourself, why is the machine generating so much garbage data in the first place?
Well, it's just the sensitivity of the equipment.
But you are describing a system where the technology is fundamentally broken, right? It's spitting out false alerts, and our solution is to hire a human being to stand there with a broom and sweep the garbage away before the nurse steps in it.
I wouldn't call it sweeping garbage. I mean, it's clinical triage.
out-of-the-box programs with highly conservative limits. You get these self-resetting warning alarms for transient things, such as, a brief heart rate limit violation when a patient just rolls over in bed.
Right. Motion artifact.
Exactly. By empowering the bedside nurses to alter those default parameters for their specific patients and eliminating those self-resetting alarms, Boston Medical Center achieved an 89% reduction in audible alarms at the source. They didn't sweep the garbage, they stopped producing it.
I see why you think that, but let me give you a different perspective on the realities of modern monitoring. I don't view the monitor technician as a human broom. I view them as an essential clinical shield. Let's look at the actual mechanism of how these central stations operate today. We are dealing with stochastic simulation models like the one developed at the University of Connecticut.
Meaning they are analyzing the randomness of the alarms.
Exactly. A stochastic model maps out the unpredictable, random nature of alarm bursts. It recognizes that alarms don't happen at an even pace, they happen in massive, chaotic clusters. When you integrate that modeling with smart communication software like Spoke, you create a highly efficient real-time triage system.
Okay, but how does that play out on the floor?
Think of a centralized monitor tech as an air traffic controller. They see the entire airspace on a massive 96 telemeter display. When an alarm triggers, the software routes it directly to the tech. They look at the waveform, instantly recognize that the patient is, say, just brushing their teeth, which causes a chaotic motion artifact on the screen, and they hit a one-button decline on their phone. The alarm dies right there. The pilot, meaning the bedside nurse, only gets radioed when there is an actual collision risk.
It's a compelling analogy, I'll give you that, the air traffic controller and the pilot. But I have to question the actual clinical value of that human filter when it comes to true accuracy. An air traffic controller is highly effective because their radar is accurate.
Right.
Let's go back to that Journal of Hospital Medicine study you cited. Yes, the monitor watchers intercepted 87% of the noise. But what about the alarms they actually did pass through?
Well, they passed through the alerts they suspected were critical.
Right, the system forwarded thousands of suspected lethal alerts. We are talking about things like asystole, which is a flat line, or ventricular fibrillation, where the heart is just quivering and not pumping blood. These are alerts that essentially scream, "This patient is dying right now." Do you know how many of those forwarded lethal alerts resulted in an actual code team activation?
I believe the number was 0 in that specific time frame.
Absolutely 0. Not a single one was a real cardiac arrest. So your air traffic controller is still radioing the pilot in a panic about clouds that look like other planes. The filter is highly imperfect. It still passes on invalid, terrifying alarms.
But that's just a byproduct.
That means the nurse still receives garbage data, but now it comes with a dangerous false sense of security because they assume the technician has validated it as a true emergency.
Look, I think you are characterizing those false positive lethal alarms as a failure. But we have to understand how medical systems are engineered. In medicine, we design systems to be intentionally overly sensitive. Why? Because the cost of a false negative, like looking at a screen, deciding it's an artifact, and missing a true cardiac arrest is death.
Of course, but
The monitor techs are explicitly instructed to act quickly. If an alarm looks like VFib and they aren't 100% sure it's just the patient moving around, they are trained to forward it immediately. That isn't a failure. That is the system working exactly as intended to prioritize safety. Frankly, I would have the nurse receive a handful of false positive lethal alarms and force that same nurse to personally dig through 20,000 baseline alerts to find the real ones.
But you are assuming the nurse's cognitive load is only tied to the raw mathematical number of alarms they hear. For anyone listening who manages complex systems, whether in healthcare, IT, or aviation, there is a massive lesson here. Alarm fatigue is much more complex than just the decibel level on the floor. It is fundamentally about a lack of control. Helplessness drives fatigue just as much as noise does.
Helplessness? How so?
When you strip the nurse of the accountability to manage the monitor, you actually increase their psychological frustration. The Boston Medical Study proved this beautifully. When nurses were given direct accountability to validate alarms in real time, and crucially, the clinical authority to adjust the parameters for specific patients, something remarkable happened. It wasn't just the heart rate alarms that dropped. System status alarms plummeted by over a third.
Okay, let's clarify system status alarms for a moment for the listener.
Good point. A system status alarm isn't a warning about the patient's heart. It's a warning about the equipment. It's the machine saying a lead is disconnected, or the telemetry battery is dying, or the signal is lost. So why did those drop when nurses were given control? Because the nurses were suddenly engaged with the equipment. They weren't just passively listening to a box scream, they were fixing the root causes.
You're bringing up the psychological impact on the nurse, which obviously I agree is central to this debate, but I draw the exact opposite conclusion about how to fix it.
Really?
Yeah. Let's look at the +1 study that investigated alarm fatigue in intensive care unit nurses. They used a statistical tool called latent profile analysis. It basically looks at a large group of people and identifies hidden subgroups based on how they respond to stress. They found that alarm fatigue is deeply, inextricably tied to emotional labor and health status.
Oh, absolutely. The emotional toll is massive.
Right, and they identified a specific subgroup called the high-fatigue negative coping group. These are nurses who are physically and emotionally drained. They are already experiencing incredibly high emotional labor just dealing with critical patients and their families.
Sure.
Forcing an already exhausted bedside nurse to constantly analyze every beep, to recalibrate alarm thresholds, to stop what they are doing to see if the parameters need widening, that adds to their extrinsic cognitive load. When a hospital hires monitor watchers, they are paying someone $17 an hour to take on that specific, repetitive cognitive burden. It is an incredibly cost-effective way to preserve the psychological resources of highly trained registered nurses who, quite frankly, need to be focusing on complex, hands-on patient care, not fighting with a machine's default settings.
I agree entirely that we need to protect the psychological resources of our nurses, but your solution fundamentally misinterprets the mechanism of burnout in this context. The +1 study actually supports my point.
How does it support your point?
It points out that nurses with higher scores on the health status and employee productivity scale, meaning they were physically present at work but couldn't fully perform due to their own health challenges, suffered the most from alarm fatigue. Think about what many of these nurses report, hearing phantom beeps in their sleep. Why does that happen? Because they feel tethered to a rigid, noisy machine that they do not control.
But taking on the maintenance of that machine doesn't automatically grant peace of mind. I mean, it grants another chore.
No, it grants agency. By giving nurses direct accountability, you aren't adding to their burden. You are removing the frustration of powerlessness. Let me walk you through the mechanism here. A bedside nurse walks into a room and assesses a patient. They see that this specific patient naturally rests at a heart rate of 55 beats per minute. If the machine is defaulted to alarm at 60, it will beep all night.
Right, a continuous low-level alarm.
Exactly.
But when the nurse has the authority to adjust that bradycardia alarm down to 50, they have just permanently solved the problem. The central tech cannot do that with the same clinical context because they aren't looking at the patient's color, or their breathing, or their comfort level. They are just looking at a squiggly line on a screen and another room.
But that is exactly why the central tech doesn't operate in a vacuum. I think we need to extend that air traffic control metaphor to explain the mechanism of the escalation protocol, because the system complexity is designed specifically as a fail-safe. An air traffic controller doesn't just look at radar, they have a dedicated multi-tiered radio system.
You're talking about the escalation chain. Yes, the escalation chain. Let's trace how this actually works in practice. If a patient's monitor shows asystole, the monitor watcher has exactly 15 seconds to intercept it and determine if it's real. If it's a less critical alert, like a lead displacement, they have 60 seconds. If the tech doesn't act, either because they intentionally forward it to the nurse or because they are busy and miss it, the system automatically texts the bedside nurse.
Okay, and if the nurse is tied up?
Well, what if the bedside nurse is busy hanging an IV and doesn't acknowledge the text? The software automatically escalates it to the charge nurse and then up the chain of command. This mechanism ensures no true critical event is ever missed. You get the benefit of human filtering to drop the noise level without losing the safety net of the machine's persistence.
Look, I understand the theory of the escalation chain, but reliability engineering tells us a very different story. Every single step you add to a process introduces a new, discrete failure point. You mentioned the Yukon stochastic model earlier, right? the one mapping out the unpredictable bursts of alarms?
Yeah.
That exact same model highlights the extreme fragility of these complex escalation chains.
Fragility in what sense? The software handles the routing.
Software relies on infrastructure. What happens when there is a delayed transmittance failure? What happens when there is poor network connectivity in a certain hallway and the text message drops? Or honestly, what happens when that central tech who is watching up to 96 telemeters simultaneously experiences a cluster of alarms during a shift change and becomes totally overwhelmed? The latencies in response times can stretch from seconds to minutes. Direct nurse accountability simplifies the workflow. You remove the network drops, the delayed texts, the overwhelmed middleman, and you deal with the alarm at the source.
Okay, I hear that argument, but practically speaking, help me understand the physical reality of the bedside workflow you are proposing. It simplifies the workflow on paper, sure, but it places all the risk and physical burden directly on the shoulders of the person who is already the most overwhelmed.
I wouldn't say.
Let's say I am a nurse in an isolation room. I am wearing full personal protective equipment, gown, gloves, mask, face shield. I am in the middle of a complex sterile procedure. An alarm goes off for another one of my patients down the hall. I cannot simply drop what I am doing, break sterility, take off my PPE, wash my hands, and go adjust a heart rate threshold. I just can't. The central tech, sitting at a desk, can address that alarm instantly.
That is exactly why the American Association of Critical Care Nurses, the AACN, issued a practice alert specifically outlining evidence-based strategies for alarm management. And their focus is heavily on proactive bedside practice, not reactive central surveillance.
Proactive in what way?
By fixing the physical connection to the patient. They recommend actions like changing the sticky ECG electrodes on the patient's chest daily and ensuring proper skin preparation before placing those leads. If you wipe the skin properly and use fresh electrodes, you drastically reduce the false alarms caused by poor signal quality. Now, let's contrast that with your central tech workflow.
Okay.
If you have a centralized system where a tech just keeps hitting the silence button on a leads-off alarm, the bedside nurse might never realize that the patient's skin prep is poor and the electrodes are dying out. The tech is effectively masking a physical care deficit. When the nurse is directly accountable, they fix the physical problem, the dried-out sticker, which naturally bypasses the need for your convoluted paging system entirely.
I don't entirely agree with that framing. I mean, the tech isn't masking the physical care deficit. The tech is the one identifying it and giving the nurse actionable intelligence. In the workflow we see with advanced integrated systems, the monitor technician doesn't just blindly silence a leads-off alarm indefinitely. They communicate. They send a targeted message to the nurse's device. Room 203, right arm lead keeps dropping.
But the nurse still has to go physically fix it.
Yes, but it allows the nurse to batch their tasks. Instead of running into the room in a panic, their adrenaline spiking because they think it's a cardiac event, they know exactly what the issue is. They can fix the electrode the next time they enter the room for a scheduled medication pass. Furthermore, we have to remember the context of telemetry.
Which is?
These patients are ambulatory. They are getting out of bed, going to the bathroom, being transported off the unit for diagnostic imaging like MRIs. A centralized monitor watcher can easily suspend the alarms in the system when they know a patient is taken off the floor. If we leave that entirely to the bedside nurse, who is juggling 5 other patients, it is incredibly common for them to forget to suspend the telemetry. The result? An hour of relentless leads-off alarms ringing at the nurse's station while the patient isn't even on the floor.
Because you are still patching a systemic behavioral issue with a dedicated watcher. The Boston Medical Center study addressed exactly this kind of workflow integration. When you change the culture of the unit to make alarm parameters a core part of the nursing assessment, just like checking a patient's blood pressure or pain level, it seamlessly integrates into their workflow. The BMC initiative didn't just tell nurses to go rogue. It required a validation from a second registered nurse before altering certain critical parameters. It made alarm management a collaborative clinical decision right at the point of care.
But what about the complex technical alerts?
They addressed those too.
They look at complex electrical alerts like R-on-T violations, which is a specific dangerous electrical hiccup where the heart's reset phase is interrupted, or couplet violations. The clinicians review the data and agree that on a general medical floor, these specific alerts rarely change their immediate medical management. So they move them from audible warning alarms to message-only visual displays. You don't need a central tech to hit silence on those. You just need to program the monitor to stop shouting about them in the first place.
I see.
My ultimate issue with centralized monitoring is that it creates a dangerous diffusion of responsibility. The nurse thinks the tech is watching, the tech assumes the nurse is responding to the escalation text, and meanwhile, the alarm is still sounding in the patient's room, increasing the ambient noise and ruining the patient's ability to actually sleep and heal.
I don't believe it's a diffusion of responsibility. I believe it is a specialization of labor, which is precisely how modern medicine handles increasing complexity. Think about how telemetry originated. It was a massive leap forward because it allowed ambulatory patients to be monitored wirelessly, so they weren't physically tethered to a wall monitor.
True.
But that innovation meant we started monitoring a much broader, generally less critical patient population than those in the ICU. Because that patient population is so broad, the default manufacturer settings are incredibly conservative. The mathematical reality is that you simply cannot eliminate all non-actionable alarms through skin prep and baseline tweaking alone.
You can eliminate the vast majority of them, though.
But you will always have artifact. You will always have transient bradycardia when a perfectly healthy patient falls into a deep sleep and their heart rate dips. A $17 an hour monitor tech, cross-trained as a medical assistant, sitting in a quiet room evaluating waveforms, is a highly efficient triage layer. They print the ECG strip, analyze it, and document it for the physician. That is specialized labor that frees up the registered nurse to actually practice nursing.
I understand the economic argument of using lower-cost labor for triage. It sounds efficient on a spreadsheet, but we have to look at the clinical outcomes of that triage. The reality is that true, lethal arrhythmias leading to an intervention are relatively rare on a general medical surgical telemetry floor. But when they do happen, they require an immediate physical clinical response, not just a documented strip of paper.
Right, which the escalation protocol handles.
But the ECRI Institute consistently ranks clinical alarm fatigue as a top technology hazard year after year. Why? Because we have seen highly publicized, tragic incidents where patients died while 10 nurses on the floor couldn't recall hearing the critical beeps.
Because of the ambient noise?
Exactly. The ambient noise level was simply too high. The BMC intervention, without adding any new technology, without relying on complex spoke software, and without hiring a single new monitor tech, reduced the average weekly combined bradycardia, tachycardia, and heart rate limit alarms by 93%. 93%! You don't need to pay someone to filter the noise if you simply stop generating it. By pushing accountability to the bedside, you create a quiet, healing environment. And the profound benefit of a quiet unit is that when an alarm does sound, it actually means something. The nurses respond immediately, their adrenaline matching the situation because they know the machine hasn't cried wolf.
Well, I think we are actually circling a very similar ultimate goal here, which is a safer, quieter hospital. But we are relying on completely different mechanisms to get there. As we wrap up this discussion, I will summarize my position this way. In a modern hospital environment, the data clearly shows that a single patient can generate hundreds of alarms per day. Even with pristine bedside practices, perfect skin prep, and customized parameters, a massive volume of noise is simply an unavoidable byproduct of highly sensitive medical technology.
That's your perspective, sure.
Right, and the cognitive bandwidth of our bedside clinicians is arguably our most precious healthcare resource. We must protect it. Centralized filtering using dedicated monitor technicians paired with smart escalation software is a proven, reliable method to intercept up to 87% of that noise. It acts as an essential shield, ensuring that when the bedside nurse's phone does ring, they know a trained professional has already laid eyes on the waveform and determined it requires their specific expertise.
And my summary is that the most sustainable, deeply rooted solution relies on clinical precision right at the bedside. Centralized filtering is, well, it's a sophisticated Band-Aid. It shifts the burden of dismissing non-actionable alarms rather than eliminating them. By empowering nurses, holding them directly accountable for maintaining equipment, optimizing skin prep as the AACN recommends, and giving them the authority to customize alarm limits to each patient's actual physiological baseline, hospitals can eradicate the vast majority of these nuisance alarms at the source. This doesn't just reduce the decibel level, it restores the nurse's clinical agency. It directly tackles the helplessness that drives emotional burnout and alarm fatigue in the first place.
It is absolutely clear that alarm fatigue remains a critical threat to patient safety and to the well-being of the healthcare workforce. Both technical filtering from central stations and rigorous bedside empowerment offer valuable tools for modern hospitals trying to solve this crisis. We encourage everyone listening to review the practices on their own units, look at the data, and consider which approach, or perhaps which synthesis of these approaches best addresses the unique demands of their clinical environment.
Exactly. Because at the end of the day, whether you are relying on a dedicated air traffic controller at a central desk or a highly empowered pilot at the bedside, the goal is exactly the same. We have to figure out how to cut through the static so that the sound of that frantic monitor actually means something again.